Good afternoon, everyone. Today, I'm very happy to present a clinical case about botulinum toxins for post-stroke spasticity. However, in this patient, the treatment was not so effective as we expected. Therefore, we really appreciate it if you could give me some suggestions or advices to improve efficacies in this patient for the next time of botulinum toxin injection. Spasticity is one of the most common complications of stroke. A long-term spasticity can lead to tendon contractures and limb deformities that can cause significant pain and functional impairment. This can impact mobility, activity of daily living, such as resting, transferring, and quality of life. Therefore, improved walking is one of the highest priority for people living with stroke. For these reasons, botulinum toxins is increasingly used for the treatment of post-stroke spasticity. However, there are still many cases do not respond to botulinum toxins or the treatment was not so effective as the patient expect. And the question is why? What are the causes of botulinum toxin failure? And these are causes of botulinum toxin treatment failure. This article was published in 2022, and the causes include inappropriate muscle injection, inappropriate doses, disease progression, changes in the pattern of muscle hyperactivity, or immunogenicity. Among these, the two most important causes are inappropriate muscle injection and inappropriate doses. In botulinum toxin procedures, the first step and also the most important step is the muscle selection. And this is the video of our clinical case. This 44-year-old patient had ischemic stroke 3 years ago, and now she presented with right spastic hemiplegia and abnormal gait. So thank you very much for your watching. And would you please give me some suggestions about muscle selection in this patient?
Oh, it's me? Well, the, the focus here is the lower limb, right? Not the upper limb. Is this your case in point? Lower limb or upper limb?
Both lower limb and upper limb, but her chief complaint is the ankle was inverted and flexed.
Yeah, because if you look at the lower limb of this patient, she has a heel strike. Did you notice it? She has a heel strike. And if there is a heel strike, then you should be very careful about giving the calf muscle injections because there is a heel strike and it's in contradistinction to a patient who walks on her toes, and upon which case you really have to give gastrocsolus injections. So in this case, what is more prominent is the is the foot inversion. Okay, so this is the varus deformity, and if it were a foot inversion varus deformity, then tibialis posterior will be a good muscle to target. One could argue whether the finger flexor digitorum longus of the toe muscles could be injected, FDL. However, if you look at it, she has curled toes and she's trying to protect herself from falling down. So it looks like I want to inject that, but on the other hand, it may be also that she needs that muscle. Okay, so we don't want her to fall down. So that's the reason why, for me, I would inject the tibialis posterior here. Maybe not sure about the gastrocnemius soleus. I would have to do passive limb function, Stardew scale. I will do some scaling to be sure that the gastrocnemius soleus or the ankle movers are affected. The other thing is that in lower limb spasticity, we are not so keen on injecting that immediately, actually, not unless needed, because sometimes when we improve the upper limb spasticity, the gait improves. There are 2 studies alluding to that. Very nice study, one of which is from Eskenazi, where he demonstrated that if you reduce the spasticity of the upper limbs, the gait of the patient improves. So if there is some financial limitations to the patient, and that is what I do in my clinics, I choose to inject first the upper limb and see if the gait will improve. What they did in Philadelphia, Eskenazi, Alberto he did kinematic analysis of lower limb function after injection of the upper limb, and it clearly showed that the lower limb spasticity improved with injection of the upper limb. And we can always argue on many things related to that in terms of neuroplasticity. So that is my thinking about the lower limb. And for the upper limb, of course, at the start, she already has this position, so one could argue that she already has a spastic dystonia. And these are the kind of patients that respond easily to botulinum toxin. And if there is especially a shoulder pain, and I would inject the shoulder movers as well. But in this case, it's clearly the elbow movers, the biceps, brachii. But if your hand goes into pronation, it's better to target the brachialis just as well, because the brachialis is a powerful elbow flexor and pronator. Unlike the biceps, which is a powerful flexor and supinator. So I would argue to inject more higher dose in the brachialis muscle of this patient. And then I will also inject the wrist flexors of this patient, FCU, FCR, just as well. Thank you.
Yeah, thank you very much for your suggestions. In this patient, where we can see clearly an equinovarus foot and also black toes, especially the red toes. Her chief complaint was the ankle was inverted and black toes. There are 7 common postures of lower limb spasticity. And we can see the patient suffer from equinovarus foot and also black toes. Equinovarus foot is the most common deformity of lower limb spasticity. And equinovarus deformity is characterized by the ankle plantar flexion and inversion. Muscles that potentially contribute to equinovarus deformities include tibialis posterior, flexor hallucis longus, flexor digitorum longus, and soleus muscles. Among these, tibialis posterior is considered the main contributor to varus deformity, as it is a major foot inverter. For this reason, in almost all cases, experts agree to target the tibialis posterior muscle for botulinum toxin injections in equinovarus deformity. In this patient, spasticity was also detected for flexors, includes flexor hallucis longus and flexor digitorum longus muscles. And in upper limb spasticity, we can see the patient had the flat elbows and also flat finger. This modified Ashworth scale, in this patient, the patient had full basic range of motion of her right ankle. ankle, and modified export scale was 2 for inverters and plantar plexus and elbow plexus, and 3 for flexor digitorum superfunctionalis and flexor pollicis longus muscles. Therefore, the next step is select botulinum toxin time and doses. The challenges if this patient is that the patient did not have insurance and also financial situation. Due to financial situation, she could not receive high dose of botulinum toxins, and therefore we have to discuss carefully with the patient about the number of muscles for injections and the doses. And after discuss with the patient, these muscles were selected. The flexor hallucis longus for the rectal flexion, flexor digitorum longus muscles for other toe flexsions, and the most important muscles is tibialis posterior muscles for foot inversions. And in this patient, we use this box with recommended dose from UK national guidelines. In upper limb, these muscles were selected. Bicep brachii for the elbow flexions, flexor digitorum superfunctionalis muscles for proximal interphalangeal joint flexors, and flexor pollicis longus muscles for thumb flexion. And after discuss carefully with the patient, these muscles were selected with the dosing below. And the last step of botulinum toxin procedures is injection guidance techniques. Nowadays, there are many injection guidance techniques, including anatomy, EMG or electrical stimulation, and ultrasound. Therefore, which injection guidance techniques is better in this patient? We can have the answer through this anatomy. This is the anatomy of compartments of lower leg. We can see this is the tibialis posterior muscles. Tibialis posterior muscle is the most central and deepest muscles of the posterior aspect of the leg. And together with flexor digitorum longus muscles and flexor hallucis longus muscles, it forms the deep group of muscles of compartments of lower leg. And there are also many veins arteries around these muscles. Therefore, it's very difficult to approach to the tibialis posterior muscles with only anatomic guidance. We cannot distinguish anatomic variation, and we cannot assess muscle depth or atrophy. So in this patient, we choose the ultrasound to localize the position of the muscle. Ultrasound also have us to continuously visualize the needle, and after that we combine with the EMG and electrical stimulation in this patient. With electrical stimulation, we can see the feedback of muscle activity of the target muscle. And in ultrasound, there are also two needle insertion techniques: in-plane injection and out-of-plane injection. In this patient, we choose out-of-plane injections. In this technique, the needle is inserted across the short axis of probe at an angle to the skin. And with our plane injection technique, the tip of the needle was seen as hyper-equipped dot in ultrasound. And there are also three approaches for botulinum toxins injections into tibialis posterior muscles in stroke patients with immunovirus put. The article was published in Toxins in 2021. And we can see there are three approaches into tibialis posterior muscles. The first is anterior approach. The second one is a posterior approach. And the last one is middle approach. And in this patient, we choose middle approach because there are some advantages of this technique. Less tibialis posterior depth. less overlying muscles, and also more tibialis posteral thickness. And the other reasons is that we are familiar with the middle approach. And this is our botulinum toxin procedures in this patient. First, we use the ultrasound to localize the position of tibialis posteral muscle. And after that, we combine with EMG and electrical stimulation. EMG have us to provide the information of muscle contraction. And when the stimulator is on, we can observe the muscle twitch of the tibialis posteral muscle. And in the ultrasound, we can see this is the soleus muscles. The flexor digitorum longus muscles is precise, and the tibialis posteral muscles is deeper than the flexor digitorum longus muscles. Continue is our botulinum toxin procedures for all the muscles. With electrical stimulation, we can see the muscle twitch of flexor digitorum longus muscles. And this is flexor hallucis longus muscles. And this is the botulinum toxin injections for biceps brachii for flexor digitorum superciliate muscles. And the last one is flexor pollicis longus muscles. This is the patient before botulinum toxins. We can see her chip complaint was the ankle was inverted and flexed. After 2 weeks, the patient said that she had improvement of the foot inversion and flexors, especially rectors. We understand that we have to follow the patient for more several weeks. However, in this patient, the treatment was not so effective as we expected. We are afraid that we missed some target muscles or the doses were not high enough. However, it's appropriate with the financial situation of the patients. And this is the adjustment of treatment for suboptimal efficacy. Therefore, in the next time of botulinum toxin injection in this patient, we intend to increase dose, increase number of muscles injected in this patient. So for conclusion, we see that botulinum toxin for post-stroke spasticity is a safe method to reduce pain and improve functionality. For botulinum toxin procedure, the first step and also the most important step is the muscle selection. Then we choose time and dose for botulinum toxins and choose injection guidance techniques. With injection guidance techniques, no supplemental guidance can replace the clinician knowledge of anatomy. So anatomy is always the most important guidance. After that, we can use ultrasound or we can combine ultrasound with EMG or electrical stimulation. Ultrasound help us to localize the muscle position and also help us to continuously visualize the needle, while EMG provide us information about muscle activity. Also, thank you very much for your attention.